We have recently published the results of our CLGB Alliance study that looked at a novel conditioning regimen and post-transplant maintenance strategy for patients with acute myeloid leukemia and myelodysplastic syndrome. This was based on two key hypotheses. One was that giving busulfan in a targeted manner somewhere at a dose level between what we used conventionally for reduced intensity conditioning regimens and for myeloablation, aiming for 4,500 level instead of the traditional 6,000 level, which you do for fully myeloablative transplants, may hit that sweet spot where toxicity and efficacy may reach a more reliable balance. Because we know that when you give busulfan and the levels are very high, you see a higher dose of toxicity like sinusoidal obstruction syndrome. When the doses are low, you see less efficacy. So we are trying to get that spot where we can perhaps have patients get the best of both worlds in that regard. In terms of the post-transplant maintenance, we followed up on pilot data that was produced by the MD Anderson Cancer Center on azacitidine as maintenance therapy, and this is done with the intent to reduce the relapse risk. So it was a package that you tried to optimize the conditioning regimen and give patients somewhat novel strategy of maintenance in an effort to overall improve outcomes. The study accrued both patients with AML and with myelodysplastic syndrome and showed that we were able to meet the primary endpoint of getting patients into that dose level on the busulfan by using a PK directed strategy. We gave a test dose a few days before the patient was admitted to the hospital for their transplant, and based on the test dose came up with the target dose which they got. So we were able to show that using the test dose, we were able to get the patients to their target dose and maintain the level that we intended to in over 80% of patients. What we also found was that the azacitidine is something that is not well tolerated by all people. We were certainly able to get a fraction of the patient through their full course of treatment, but quite a few patients dropped off because of either side effects from the drug or other complications that we associate with transplant, including graft versus host disease and infection risk. But overall, the package did show that we met the desired endpoint of a 2-year progression-free survival that we had targeted, and this is something that in one way we are happy that it is a positive study, but in the other way it's just the building blocks for future trials because the study size was relatively small, but the concept can be taken to the next level because we, I think, do need perhaps better measures still as disease relapse remained a problem despite the optimization of the busulfan and attempts to give azacitidine to patients. So this study is something that will add to the literature on the correct intensity of our treatment and the utility of maintenance strategies.